Good evening, everybody. Sorry for the brief delay. We were having some connectivity issues, but thank you for joining us for this December CIS Case Conference webinar hosted by CIS and our ECI members. We're very appreciative that you could join us in this busy holiday season. Our first case is being presented by Jenny, who is our fellow at Nationwide Children's, and our senior mentor is Jolan Walter from All Children's in the University of South Florida. So Jennifer or Dr. Yonkof, if you want to get started on your case. Actually, sorry, and I'm Kelly Williams. Sorry for people who don't know me. I'm the ECI committee chair, and I'm going to be moderating this session. So if anybody has questions or anything, just put them in the attendee chat. Jenny, I'm going to probably stop you intermittently to try and engage the group. And then, Jolan, we can get your wisdom and share your expertise on this with us.
Okay, well, thank you very much for the introduction and for this opportunity. I would just like to address, I think Dr. Walter is having issues hearing us, so if someone would be able to work on that in the background, I would be happy to get started with the case presentation. So our patient is an 11-year-old African-American female who was referred as a second opinion, coming with a known or established diagnosis of CVID, as well as lymphopenia, recurrent HSV stomatitis, and cutaneous granulomas, with particular interest in evaluation of her skin lesions and concern for underlying osteomyelitis. You can see in these photographs that she has pretty significant destructive lesions involving the nasal bridge and cheeks. And then the picture on the far right is her posterior right thigh. These lesions developed around 4 years ago and had been progressively worsening with minimal response to systemic steroids. Her history was otherwise significant for recurrent infections that began when she was in early school age. She had community-acquired pneumonia requiring hospital admission on one occasion, as well as a right knee abscess that was drained in the ED with unknown culture results. And then she also
sorry, Jenny, I'm going to hold you real quick. Can other attendees hear us? If so, can you just, okay, good. Sorry, just because one of the attendees just messaged that she couldn't hear audio, but somebody else messages they can, so we're good.
Okay. As well as recurrent HSV stomatitis that was controlled with Valtrex. She tolerated live vaccines, and as you could see from the previous pictures, she was normocephalic and had normal growth and development with no evidence of facial dysmorphia. There was no family history of immunodeficiency, autoimmunity, recurrent or hematologic malignancy. And she had, I believe, 2 younger siblings. So she had been started on IVIG when she was in middle school for a presumed diagnosis of CVID, but around the age of 9 years old developed the granulomatous lesions that became progressive and were shown in the previous photographs. She did have a biopsy obtained in February of this year that showed sterile necrotizing granulomas, with a negative universal PCR and AFB stain, and that was repeated on a second admission, and again was negative for an infectious etiology that was readily identifiable. And like I said, she really had a pretty transient and unclear response to systemic steroids. And this is a picture of the CT scan that demonstrated significant osseous involvement underlying her cutaneous granulomas that were felt to likely represent the same inflammatory lesions. She had an extensive ID evaluation from the blood that was negative, as well as from the skin tissue. And on review of her chart, we identified progressive T and B cell lymphopenia with normal NK cell enumeration that began around the age of 6, consistent when she developed a clinical phenotype of recurrent viral and sinopulmonary infections. So at this point, I would like to summarize her case, we have an 11-year-old female with T and B cell lymphopenia, recurrent HSV stomatitis, and progressive severe cutaneous and osseous granulomatous lesions, who is presenting for further workup. So I would like to ask the audience what kind of things you would consider in your differential.
So we have Amit, who has suggested a RAG 1 or RAG 2. Anybody else have any other suggestions with granulomas, lymphopenia?
It looks like MHC class 1 or a TAP deficiency.
A great idea too.
I think a big point that we wanted to address here was that there are a number of clinical and laboratory red flags to indicate that this isn't an isolated humoral deficiency and is really representative of a combined immune deficiency given her T-cell lymphopenia, predominance of viral infections, and
Maybe another suggestion for ataxia telangiectasias, which
yes.
And they're asking if neurologically, if this patient is normal.
She is. So those were some of the other things that I think historically are important considerations, but may seem less likely would be other forms of things classically associated with T-, B-, NK positive SCID. So Artemis, DNA ligase 4, Cernunnos are more commonly associated with microcephaly and other neurologic disorders. So those are all really good questions. But she did not have those things.
Great.
All right.
Well, we can continue.
So when we performed her immunologic phenotyping, we saw a distinct paucity of recent thymic emigrants and naive T cells and marked expansion of senescent and exhausted T cells in both the CD4 and the CD8 subsets. You can see that her CD4 RTEs are only 11% of her T cells. She had impaired ability to form central memory cells. And there was significant expansion of the PD-1 exhausted subset at 73%. And then similar findings were reflected in the CD8 compartment where 85% of those cells were exhausted HEMRA cells. And when we looked at her T cell function, we actually found that she had robust recall antigen responses to both Candida and tetanus. PHA was reduced at around 67,000, but that may be reflective of her baseline lymphopenia given the radioactive method was employed, which is looking for a gain of signal that doesn't take the baseline lymphopenia into account. And we did consider that there was a potential for some polyreactive clones within the T cell compartment contributing to the robust vaccine proliferative responses that we observed. When we looked at her TCR V beta spectrotype, we also saw that she had increased oligoclonal and non-Gaussian distribution of many of the families. So it was looking like she had replicative senescence of oligoclonal T cells within the periphery. Her humoral evaluation was also reflective of a deficient capacity for class switching and memory formation. She had reduced transitional cells. Most of her B cells were naive, and she had an enriched population of CD19, CD21 DIM B cells that are peripherally homing autoreactive B cells. Similarly, she was found to be hypogamma-globulинemic with deficient polysaccharide-specific responses at the time of CVID diagnosis around 6 years prior. We performed autoantibodies directed against type 1 interferons and IL-12 after making her final diagnosis, which were negative. And her bone marrow was normal cellular with undetectable plasma cells, and no granulomas on the iliac crest that we got. Ultimately, we performed a primary immunodeficiency genetic panel and identified a compound heterozygous RAG1 variant. So she had two identified pathogenic variants that are both associated with reduced residual recombinase activity, around 30 to 40% of wild type based on previous studies. Most of those patients similarly presented with either an Ullmann syndrome or a combined immune deficiency with granulomas and autoimmunity type of phenotype. You can see this picture is kind of describing or showing the RAG1 gene structure. So her first allele was within the nonomer binding region and is associated with reduced protein expression, as well as reduced affinity for the actual RSS sequence. And her second variant was just upstream of the heptamer binding region and is similarly associated with reduced expression and recombinase activity. So just as a quick review, the RAG protein complex is involved in VDJ recombination, as well as class switching and somatic hypermutation. So it's playing a role in both the generation of your B and T cell repertoire, as well as receptor editing within the B cell compartment. RAG1 is the catalytic unit, and you can see here that the V regions are actually kind of uniquely selected in RAG mutants, and there's a reduced affinity for distal V gene segments and an increased affinity for segments that ultimately propagate autoreactive clones. So you're generating a less diverse repertoire and a more autoreactive repertoire. So this is a nice slide from a review paper kind of describing the phenotypic spectrum of RAG variants. Of course, we traditionally think of this as being associated with SCID or Ullmann syndrome, but actually a growing body of patients are being identified with this later onset presentation, characterized by marked autoimmunity and hyperinflammation. And really the recombinase activity level is directly correlated with the immunologic and the clinical phenotypes. So of course, at one end of the spectrum, if you really have no recombination activity, that would be associated with marked lymphopenia and a SCID phenotype. But patients who have CID-GA have a host of other immune problems that predispose them to autoimmunity. So they can develop reduced air expression by MTEX, derangements in the ILC compartment that I will show next, reduced Treg suppressive capacity, and then this chronic lymphopenia is resulting in increased level of BAFF that promotes the survival of autoreactive clones, increased levels of cytokines that promote NK cell cytotoxicity in that compartment, and some other derangements in innate immunity. Whoops.
Sorry, let me. Someone's asking if the granulomas were due to rubella.
That is a great question. They were, and I will show that in a couple of slides. But first, I just wanted to present some other interesting data that Dr. Notarangelo and Carrie Dobbs were kind enough to perform and to share with us. So what this first panel is showing is distal usage or usage of distal V gene segments. So in this population, there's reduced ability to utilize those most distal segments. So you can see that they're essentially absent in the T cell compartment, and that a very specific locus, the alpha chain 7.2, which in combination with CD161 characterizes mucosal associated invariant T cells, is also absent. So that is a relatively sensitive marker for this disease. And you can also see on the right that the ILC subsets are also atypical. So compared to a healthy donor, there's expansion of the overall ILC subsets that's mostly attributed to the ILC2 and ILC3 specific subpopulations. So this really isn't limited to the adaptive arm of the immune system, as you might expect. And then there's also reduced expression of CCR9, a chemokine receptor that facilitates trafficking to the small and large bowel, as well as CD162. So there may be defective T cell homing to both the skin and to the gut. Regarding the granulomas within this specific phenotype, around 25% of patients will present with them. They are most commonly limited to the skin, with lungs being the most common visceral etiology, and essentially they are very recalcitrant to any number of immunosuppressants. Steroids and TNF alpha inhibitors have been used most commonly, but at most 20% of patients tend to respond. So really, allo-HCT is the definitive therapy for this disease and the most effective treatment for the cutaneous granulomas. So as one of our audience members aptly pointed out, vaccine strain rubella is being found more commonly within granulomas of patients with PIDD, initially identified in some of the other radiosensitive forms of SCID that involve non-homologous end joining, but emerging in a variety of other CIDs, including RAG patients. And like I said, HCT is really the most effective therapy. You can see the picture on the right shows granulomas pre and post-transplant.
And so, sorry, if you can just, I'm going to stop you a second, Jenny, but so when you had them done, you specifically asked them to look for rubella in it?
Yes, we actually had to send samples to the CDC. So we looked in both skin, blood, and urine, and she only tested positive within the lesional skin.
Okay, great.
So you can see here, this is immunofluorescence staining from one of the granulomas, showing the capsid in red within the M2 or alternatively polarized macrophage population, which is green. So that seems to be the reservoir for these viruses, is these alternatively polarized macrophages. So there's some thought that the general immune dysregulation relating to this disease is allowing expansion of those cells and persistence of the virus, since there's a defect in the CD8 cytotoxic T cells. So our patient underwent allo-HCT, and she is just shy of being 2 months out from transplant today. She received a myeloablative transplant using alemtuzumab or Campath, busulfan, and fludarabine. We did target myeloablative dosing given her expansion of autoreactive T cell clones and known enhanced NK cell cytotoxicity to promote engraftment. She had pretty minimal to no end organ damage going into the transplant, so we felt that she would tolerate those higher doses. And while specific regimens are less studied within the CID-GA population of RAG mutants, the use of chemotherapy and serotherapy is associated with higher quality immune reconstitution and reduced long-term need for IVIG within the Omenn syndrome population. She is receiving tacrolimus GVHD prophylaxis and hasn't had any manifestations of that yet. Her transplant course was fairly uncomplicated. She had mild VOD that resolved and adenoviremia without evidence of end organ damage. that's being treated with cidofovir. At day plus 30, she has around, sorry, some of that is covered, but 65% chimerism in the T cell compartment and 99 within the myeloid compartment. And she is still not lympho reconstituted in any compartments at this point in time, but we're planning on repeating those tomorrow.
Great.
So in summary, we wanted to hit home that patients who have hypogammaglobulinemia may have combined immune deficiency, and it's particularly important to consider if there are any phenotypic features suggestive of a defect in cell-mediated immunity, such as recurrent HSV in this patient, and also that these lymphocyte functional defects may be progressive over time. So it's important to be dynamic in your evaluation of the patient and to not get into a limited diagnostic box. Of course, early diagnosis of treatment can prevent both infectious and non-infectious complications. Vaccine strain rubella is becoming an emerging complication within later onset forms of combined immune deficiency. And the CDC is really the linchpin in helping to diagnose that at the time. We wanted to emphasize that the phenotypic spectrum of RAG deficiency can range anywhere from SCID to combined immune deficiency with granulomas and autoimmunity, and particularly young toddler age children with recalcitrant cytopenias would be another important phenotypic presentation to consider. And this can involve both adaptive and innate immune dysregulation. Allo-HCT is the preferred and curative treatment for any form of RAG deficiency, and some particular considerations are that recipients will have increased NK cell cytotoxicity, enhanced survival of autoreactive clones, as well as lymphocyte radiosensitivity, secondary to the defect in DNA double-stranded break repair, that are all pertinent considerations when you're planning the transplant. Are there any questions or comments?
Jenny, that was a great case about the more granulomatous presentation of RAG. Yeah. Does anybody have any particular questions about granulomatous diseases or combined immune deficiency specifically related to granulomatous manifestations?
This is Dr. Walter, and I am the mentor for Jenny. Jenny, excellent work. I'm really proud of this beautiful presentation. I have one comment in the key points is whether these patients could be actually identified before they're declared their disease. Do you think there's an opportunity for us with newborn screening to find these patients in a relatively asymptomatic form?
I think that it would depend on the residual recombinase activity. Looking back at some of her older CBCs, she didn't have a reduction in her total ALC until she was approaching school age. So I do think that there is the potential to miss some patients who have high recombinase activity on the newborn screen.
It's a very good point. However, we don't know how many of those lymphocytes were actually naive. And as you have pointed out, around 10% were at this point naive. So it is still possible that she had a homeostatic expansion of her T cell compartment that led to oligoconality. So I'm still having some hopes that as we are moving forward with newborn screening, some of the patients will resurface and maybe we can avoid the complication that she's clearly suffering from. This is very impressive images that you have shown to us.
Thank you for that insight, Dr. Walter. It's definitely something that we will probably encounter more of because newborn screening is in every state. Anybody else have any other questions before we move on to the next case? Okay. I think if no other questions, we'll move on to the second case. Thank you so much, Jenny and Dr. Walter, for your participation.
Thank you.
Thank you.
Thank you.
All right. Hello, everyone. My name is Shannon, and I am one of the trainees at the University of Manitoba, so in Winnipeg, Canada. And I just wanted to say thank you to Dr. Tamar Rubin for providing the patient case that I'm going to present today. And kind of going along the same theme as the last presentation, where a diagnosis of CVID may not be quite as it seems. So this case is a 36-year-old male patient who initially presented to the adult immunology clinic with recurrent lower respiratory tract infections, and at the time he was 25 years old. As a result of initial investigations with hypogammaglobulinemia and decreased specific antibody responses to vaccine antigens, he was ultimately diagnosed with CVID. So looking at his initial investigations, he did have some very obviously low immunoglobulins, so Canadian units there, but low IgG and very low IgA and IgM as well. On his lymphocyte enumeration, the very first one, he had elevated CD3, CD4, and CD8 cell counts with low CD19, but not undetectable. Initially, he also had an abdominal ultrasound, which measured his spleen at the upper limit of normal, and he did have a bone marrow biopsy done by a hematologist to rule out hematologic malignancy at the time before he was referred to immunology. The rest of his blood counts were within normal limits. So, just a question for the group, considering a differential diagnosis for a patient presenting initially with hypogammaglobulinemia, decreased specific antibody responses, and recurrent lower respiratory tract infections.
Okay, so we're getting some answers. Combined immune deficiency, CTLA4, PI3K gain of function. There's a question about whether the antibodies were low or actually undetectable within the lab. The vaccine titers, I'm guessing.
That's a great question. I'm not sure.
Yeah, so I also, it's Tamar here, I don't remember either, whether they were undetectable or low, but I think given his very significant hypogam, they were probably undetectable.
Yeah.
But I'm not 100% sure on that. We've got another few options suggested, NF-kappa B1, LRBA, and also, did you consider the profoundly low IgG as suggestive of an alternative to CVID?
Great point. Yeah. All right. So this is just a very brief list of some things that might be on your differential for hypogammaglobulinemia. And of course, all the other ones that people have mentioned are also great ones to have on the list. So we'll we'll carry on from there. But essentially, after his diagnosis of CVID, he was started on IVIG, and this did result in a decrease in the frequency of his lower respiratory tract infections. And he was essentially stable on IVIG for about 8 years. At which point he developed edema and dyspnea, and he was found on investigation to have anemia, thrombocytopenia, and splenomegaly. At that time, he had a workup which was negative for lymphoma and had no evidence of pulmonary hypertension. The cytopenias, so the anemia and the thrombocytopenia, were responsive to steroids, and it was presumed to be an autoimmune hemolytic anemia, despite a negative DAT, and that was thought to be because of his hypogammaglobulinemia, that was negative. He also, shortly after that, developed transaminitis and hyperbilirubinemia, and then subsequent biopsy of the liver revealed reactive lymphocytic infiltrates. He had another bone marrow biopsy, which showed reactive lymphocytic infiltration, panmyelosis, and a grade 1 fibrosis. He then had further workup for looking for lymphoma, including a CT chest, abdomen, and pelvis, which showed hepatosplenomegaly, but no other evidence of lymphoma. So at that point, he did undergo genetic testing, which did reveal a diagnosis, which was the pathogenic variant in the SH2D1A, which is the gene that encodes for the SLAM-associated protein, or SAP, which is responsible for mediating activation and interaction of T, B, and NK cells, affecting their cytotoxicity, cytokine production, and antibody production. And so because of this pathogenic variant that was found, a diagnosis of XLP, X-linked lymphoproliferative disease type 1, was made. And so this is a fairly different presentation than what sort of the classical X-linked lymphoproliferative syndrome presents with, which is with fulminant EBV and HLH. These patients are at risk of B-cell lymphoma, but also have other clinical features, including a lymphocytic vasculitis, aplastic anemia, as well as colitis. They can also develop hemolytic uremic syndrome and other features of autoimmunity, including cytopenias, which were seen in this patient, nephritis, and thyroiditis. So in terms of considering genetic screening in CVID, there is suggestion that male patients with hypogammaglobulinemia should be screened for X-linked PIDs, as there are different strategies for management of X-linked conditions like XLA, XLP, and X-linked hyper-IgM than there are for CVID. And a recent study from 2018 screened 150 and then an additional 80 male patients that were initially presenting with hypogam, and 2 were reclassified as XLP after they identified a mutation in the responsible gene. And so this just shows how with genetic screening for those male patients, they were able to make a diagnosis of X-linked hyper-IgM, XLP, and XLA with a BTK mutation. So in terms of the dysgammaglobulinemia, about 1/3 of patients with XLP will develop dysgammaglobulinemia without an episode of fulminant EBV, and this can be the initial presentation. They may have normal numbers of B cells, but have a low proportion of CD27 positive memory B cells that express IgG. And the SAP deficient T follicular helper cells result in reduced germinal center formation, reduced isotype switching and reduced B cell maturation. And so most B cells, memory B cells in XLP patients produce IgM, but not IgG because of defective naive B cell differentiation, as the germinal centers are critical for that isotype switching. And SAP plays a role in the CD4 positive T cell promotion of B cell differentiation into plasma cells, demonstrating that there's a problem inherently with the T cells as a result of that SAP protein, and it's not just an inherent B cell problem. So going back to our case, so last year he was admitted to hospital with community-acquired pneumonia. He was found at that time to have right-sided cardiac volume and pressure overload. He had worsening of his autoimmune hemolytic anemia and thrombocytopenia, as well as liver injury, thought to be possibly due to hemolysis. At that time, he was treated with corticosteroids and IVIG. And due to the severe thrombocytopenia and concern for possible malignancy, he had a splenectomy. And when they looked at the spleen itself, there was marked congestion of the red pulp, no extramedullary hematopoiesis in the spleen, and it was found to be not part of a myelofibrosis picture. His postoperative period was complicated by retroperitoneal hemorrhage, requiring an exploratory laparotomy and evacuation for the bleeding. And then subsequently, he had an improvement in his reticulocyte count, his LDH, bilirubin, and platelets postoperatively. He also, because of some more concerning features for malignancy, including weight loss, night sweats, and lymphadenopathy, was admitted to hospital for bone marrow biopsy and then subsequently developed further bleeding from that site. This was treated with IVIG, tranexamic acid, and platelet transfusions. And when they did do a CT angiogram, they couldn't demonstrate any vessel involvement. So it was thought to be bleeding as a result of an acquired functional inhibitor of factor 13. And he continues to have symptoms of ongoing epistaxis and gum bleeding as a result of his bleeding diathesis. So over the past year, he's had about 20 pounds weight loss. He's had night sweats several times per week, and he has axillary lymphadenopathy as well as a progressive thrombocytopenia. He also has a normocytic normochromic anemia and then has lymphocytosis, monocytosis, and eosinophilia on his white blood cell count. His stools have been negative for ova and parasites, and a tagged white blood cell scan was negative for an occult focus of inflammation in the retroperitoneal area.
So there's just a question from one of the attendees about if there are any other features of HLH, and then a secondary question as to whether or not he was investigated for an EBV-associated lymphoma.
Yeah, great questions. So I don't believe there were any other features of HLH, and certainly EBV-associated lymphoma has been on the differential with concern for that, absolutely. So he did have some specific immune testing and T-cell clonality testing by qualitative multiplex PCR targeting TCR beta and TCR gamma genes did identify a clonal TCR with gamma delta double negative T cells. And his most recent bone marrow biopsy revealed a hypercellular marrow with increased granulopoiesis and erythropoiesis. There were also interstitial aggregates of small and mature lymphocytes with CD4 positive T cells and a focal increase in interstitial B cells. There was mild fibrosis seen on the bone marrow as well. So in terms of his current infectious history, so over the past year, he's had 4 episodes of sinusitis, 1 episode of pneumonia, 1 episode of acute otitis media. He's had persistent palmar warts and consistently has diarrhea several times per week. So he continues to get IVIG every month and is on amoxicillin twice a day as post-splenectomy prophylaxis. And we have been doing EBV quantification on a monthly basis, which I'll show here. So initially, November 2017, his EBV was not detected. In April 2018, it was detected but not quantified. And the first quantified EBV we have for him is from June of this past year. It subsequently peaked in August, and then September, October, and November, it's been detectable, but at less than 575 copies per ml. So this is, of course, unusual in a patient with XLP. So we have thought about whether he is able to control EBV with somatic reversion of lymphocytes that permits the normal protein expression and function. And we did send off a test for measuring the SAP expression through the Cincinnati Children's Lab. Dr. Rubin, correct me if I'm wrong, but I believe that he did not have any SAP expression.
Sorry, I just need to unmute myself there. I was just trying to look at the report. So I'm going to pull it up right now. So he had 0% SAP positive NK cells and 4% SAP positive CD8 cells.
So they are revertant cells? Right.
Sorry?
They must be the revertant, the CD8.
Yeah, so that was what we had thought for the CD8 positive cells.
Right.
That's
yeah.
Interesting that only 4%, that usually in these patients, those revertant cells are up much higher. I wonder, part of the lymphocyte infiltrates elsewhere, maybe more of the revertant population, less in the circulation.
Great point. Yeah. And so on his most recent CT, he did have prominent lymphocytic tissue in Wilder's ring with multiple small bilateral cervical lymph nodes, but these were unchanged in size from previous imaging. And on previous imaging, he also had right lower quadrant mesenteric lymph nodes as well, which can be a location for a gastrointestinal lymphoma. So typical management of a patient with XLP would be management of HLH if they have fulminant EBV with dexamethasone, etoposide, and then methotrexate and intrathecal hydrocortisone if they have CNS disease. They can have IVIG for antibody deficiency, and then, of course, treatment of any lymphoma if it's found. But hematopoietic stem cell transplant is considered curative. And so this is something that we have been looking into for this patient. And so the question is now, is it time for transplant at this point? This is a patient who had been fairly stable for the first 8 years on IVIG, but then developed a number of multiple organ systems involved. So the risks versus the benefit of transplant at this time, given his ongoing concerns for possible malignancy. We did measure the SAP expression, and so we are considering stem cell transplant before any further complications develop. We are considering investigating further for GI lymphoma before transplant, and also considering rituximab to deplete the B cells as the source of EBV and reduce lymphoproliferative disease. So in terms of his initial stem cell transplant assessment, his sister is a match, but is a carrier for the same mutation. His brother is not affected, but is not a match, and they have found an unrelated donor that's a 9 out of 10 HLA match. And so in terms of donors for patients with XLP, they should be EBV exposed. And his sister could be a donor as long as she has normal X lionization, a normal immune screen, and at least 50% SAP expression. So we are interested in your thoughts and your experience. Has anyone had any experience transplanting an adult patient with XLP? Would it be preferable to transplant from his carrier sister or the matched unrelated donor? Should we pursue using rituximab before transplant? And if we did decide, or he decided not to pursue stem cell transplant, are there any other options for long-term management and any further assessment for somatic reversion of the T cells, which we've kind of discussed a little bit already?
So there was a question about checking for invariant NK T cells. That isn't something we've done, and I'm actually not sure where one would send that or how that would be tested, but that would be interesting to consider.
I just want to step in here and just to thank you for kind of bringing up XLP and presenting as a CVID-like presentation and reminding us more of the more historic type of immunodeficiency, as well. We are so much more indulging with the newer kind of exciting other defects. And stepping back and thinking about X-linked hypogammaglobulinemias and remembering that. And I just was thinking that the frequency of the number of new CD4 ligand or XLP diagnosis within the last 5 years have dropped or decreased, in at least on my side of the world, and that's probably because most of the obvious ones have already been diagnosed, and we are now more indulging into the so much more unknowns. I think this is a great case, and also to review what future holds for these patients with XLP. And I do think that there's no doubt in my mind that these patients, especially somebody who has had such a complicated course, should be transplanted. How and when are good questions, but I think while this patient is stable, not when you're trying to get him out of HLH or massive lymphoproliferation, this is the right time to go for transplant. Doing rituximab or not, it depends on what conditioning regimen I guess you'll use. If you're going to use Campact, our transplanters do not necessarily go ahead with rituximab immediately before the transplant if they're going to end up using Campact. So it just depends on the ablation regimen you are going to use. Looking for somatic reversion, I don't know if that necessarily will add anything. These cells that are somatically reverted, CD8 T cells, which happens in almost all XLP patients once they see EBV, these are EBV reactive cells that they revert. They are usually PD-1 positive, and they are not necessarily functionally relevant CD8 T cells. So they may be more resistant to kind of like clear. This is expanded cell population, mostly clonal T cell population. So I don't think it will help you in any ways to escape or delay transplant. But from the scientific point of view, it's just kind of exciting to explore those cells. That's all I would say.
Thank you very much for that insight.
I guess if there are any other transplanters, it would be interesting to
Carl's asking
get
if
their point.
you were able to check invariant NKT cells.
Yeah, that isn't something that we did check.
Sorry, I missed that.
Mm-hmm. Yeah, I guess, one of the questions that had come up for us is when this patient was seen, over a decade ago and diagnosed with CVID, had they had some sort of genetic screening because they were a male patient, because they were so hypogammaglobulinemic? We would have figured out that he had XLP rather than CVID. But I think the decision to transplant such a patient might have been challenging for a patient who otherwise really had only suffered from relatively minor sinopulmonary infections, community-acquired pneumonia treated as an outpatient. So, I think in retrospect, it would have been preferable to have known and as soon as the early complications started or before any complications started, have dealt with it. But access to genetic testing at that time was a lot more challenging, and now our center is much more generous with approving gene panels and even exome sequencing. So we've been lucky in that regard to be able to diagnose some of our patients who've been mysteries for many years.
I wanted to tell you that was one point about the factor 13 inhibitors that this patient developed. That is something actually quite interesting, and we recently run into the same problem in one of our PI3K patients, and it was like a neighbor able to, our hematology lab at the time was able to measure the state. They have these units in Bethesda units, the amount of inhibitor, and we were able to give this patient rituximab because these are autoantibodies in a way, and was able to reduce the amount of factor 13 inhibitor, and then following that, we were able to take the patient to transplant. So it is an interesting phenomenon in patients that make a lot of autoantibodies with this regulated B cell.
Thanks. That's very helpful. There's another question from Carl. Can you please explain the relevance of somatic reversion?
I'm not sure I can do that great justice, but basically just looking at whether there are T cells that, have reverted back to normal SAP expression. So, most of the T cells would be lacking SAP expression in a patient with XLP, but somatic reversion of those T cells in response to like a viral infection like EBV would result in them not developing fulminant EBV and HLH, and instead being able to control the EBV infection, which is not what you would expect in a patient with XLP.
So these reverting T cells in XLP specifically happen once the patient gets exposed to EBV, and these reverting T cells are EBV specific. So EBV infection itself drives the reversion. Unfortunately, they are not specifically functionally relevant T cells as one would hope. But it just tells you, when you look at a patient, if there's a reverting population. Cutaneous has shown this in a revertant CD8 T cell in an XLP-based patient. You pretty much predict that the patient has been, if you don't know the EBV status, that patient has seen exposed to EBV. And the reversions happen in other immune defects too, as you know, like ADA SCID or Scott. In other immune defects, it's not exactly known what infection or what factor drives this somatic reversions, but in this defect, it's known that they are EBV specific EBV responses.
Thank you.
There's another question asking if we sorted the cells expressing SAP and sequenced them. No, we did not get to that.
What would be the point for that? The point would be sometimes the reversions are to the wild type, and sometimes the reversions are not to the wild type, but to another amino acid that is close to the function of the wild type amino acid. So that would be able to allow protein expression. So that's kind of like, from the scientific standpoint, would be interesting to know if the reversion was to the wild type or to another amino acid.
Okay. Great. Thank you very much. I think I'm going to hand over now to Kelly, who is going to talk about the journal article if there are no more questions.
Great.
Thank you very much.
Morgan's pulling up just a few slides. So for the last few months, we've been trying to do a quick review, 5 minutes or less, of an article that came out in the last month related to clinical immunology, just high yield. And so I picked this article that came out in Jockey from our very own Jude, who's on our ECI committee. And it was specifically looking at prophylactic antibiotics versus immunoglobulin replacement in specific antibody deficiency. So the main objective was to compare treatment outcomes in patients with specific antibody deficiency who were treated with prophylactic antibiotics and or immunoglobulin replacement therapy. And they did a retrospective chart review of 65 patients who had specific antibody deficiency. And then they received treatment at 2 tertiary care centers. Texas Children's was one center and CHOP was the other, from 2012 to 2017. They specifically looked at clinical and laboratory data, as well as treatment and rates of infection, as well as hospitalizations. And they looked at these and compared them pre and post initiation of treatment. So just 2 big slides, and then one of them is just looking at the actual study population. So the N was 65. The mean age was 18 years old, with quite a range of 2 to 71. And these are all sums, but 45% were people who ended up receiving immunoglobulin replacement therapy. 11% received prophylactic antibiotics. 11% received both. And then 23% received prophylactic antibiotics initially and switched to immunoglobulin replacement. And I thought that this slide was helpful just because they also looked at it and stratified by phenotype, whether it was mild, moderate, severe, or memory phenotype, to look to see if the phenotypes had any impact on whether or not they failed or did okay. And specific antibody deficiency phenotype was not predictive of rates of infection within 1 year. And this is, kind of an obvious slide, but looks at the median number of infections 1 year before treatment and then 1 year after treatment. And clearly both treatments are effective and did very well at reducing the number of infections. So the key results were, after 1 year of treatment, the difference in the mean number of infections in people who received prior prophylactic antibiotics versus immunoglobulin replacement therapy was not statistically significant. And then two things I thought that were important to mention were the odds ratios. And for patients who reported autoimmunity, they had an increased odds ratio for having persistent infections after 1 year. And the higher levels of IG, and they looked at them for, so higher levels of IG had a decreased odds ratio of persistent infections. And so I thought those were just important to note. And so their conclusions were just prophylactic antibiotics. There's no statistical difference between them. They both were not statistically significant. So prophylactic antibiotics and immunoglobulin replacement therapy are both equally effective in preventing infections. And then this may obviously also seem obvious, but patients who fail prophylactic antibiotics may benefit from switching to immunoglobulin replacement therapy. So we've all been using these in practice, and I thought it was important that someone actually looked at this. And so in terms of first-line therapy, I think it's important to, talk with our patients and try and figure out what works best for them. Okay, that's it. Thank you all for sticking with us for the whole hour. Sorry again for the late start. Okay, thank you. Have a good holiday, everybody. Great cases.